Good day, my name is Michael Rooks. I'm coming to you from Port Orange, Florida. The topic of today's presentation is functional anatomy of the hand. The human hand is a miraculous structure. It is our primary method of manipulation with the external world. Understanding the hand's unique anatomical structure and how it relates to function is a prerequisite to recognizing and treating illnesses, injuries, and anomalies of the hand. References for this presentation include multiple articles and text. Nevertheless, the primary reference is Paul Brand's Clinical Mechanics of the Hand. A close second is Kaplan's Functional and Surgical Anatomy of the Hand, more recently edited by Morton Spinner. As an organ, the hand presents several recognized patterns. Coordinated grip allows a strong grasp necessary for tool usage and other vigorous interactions. A wider grip aided by abduction and adduction of the fingers provides manipulation to larger objects, lifting, and support. Tip-to-tip pinch is present between the thumb and most, if not all, digits. Tip and side pinch provide fine object manipulation, and key pinch provides a more firm grip on small objects. Excluding the sesamoids, the hand has 19 bones, 5 metacarpals, 1 in each digit, and 14 phalanges, 3 in each digit except for the thumb, which has only 2. The metacarpal phalangeal joint is a biaxial joint with significant flexion and limited abduction and adduction. The proximal phalanx is attached to the metacarpus with a fibrocartilaginous volar plate. The metacarpal attachment is more flexible and includes 2 check ring ligaments that limit extension. Each joint has a capsule. Within the capsule is 2 collateral ligaments that serve as checks against abnormal movements. They are generally not stressed during normal joint motion. There are also 2 accessory collateral ligaments. The main function of these ligaments is to suspend the joint annular ligaments and prevent flexor tendon bowstringing. The cartilage over the metacarpus at the metacarpal phalangeal joint of the minor digits is significantly wider at the volar aspect when viewed in the transverse plane. This limits abduction and adduction with joint flexion. There is 25 to 30 degrees of full extension and essentially none at full flexion. The interphalangeal joints are similar in capsular and ligament structure. However, these are single-axis joints. Pure hyperextension of the digit produces the greatest leverage at the metacarpal phalangeal joint. A dorsal dislocation requires disruption of the volar plate attachment. If this occurs at the phalangeal attachment, a simple dislocation occurs. The collateral ligaments may remain intact and will tend to rotate the phalanx dorsal. A closed reduction by distraction, aided by hyperextension of the phalanx, is to be anticipated. If the volar plate disruption occurs more proximal, volar plate entrapment on the dorsum of the metacarpal can occur. This is likely if the collaterals remain intact. The volar plate will lessen or eliminate the dorsal rotation of the collaterals, and a more parallel attitude is to be expected. This is the essential feature of a complex dislocation, and an open reduction is to be expected. Most of the joints in the hand function as third-class levers. The force acts between the fulcrum and the load. These forces are described as torques or statically as moments. Torque is the product of the force or load acting at a right angle to the moment arm extending from the center of rotation. The greater the moment arm for the force, the less tension force is required for a given load, but required exertion is increased. For illustrative purposes, we can consider the tendon tension moment arms of the distal interphalangeal joint, proximal interphalangeal joint, and metacarpal phalangeal joint to be 0.50, 0.75, and 1 centimeter respectively. Similarly, we can consider the load moment arm of a 20 Newton force pushing up against the fingertip. For the same joints, this would give a 2 centimeter, 5.5 centimeter, and 10.5 centimeter moment arm. The tension and load torque forces acting across each joint can be calculated. The distal interphalangeal load torque is 0.4 Newton meters, 20 newtons times 0.02 meters. Flexor digitorum profundus tension torque must equal this for stability. 0.4 Newton meters divided by the tension moment of 0.005 meters gives a tension force of 80 newtons for the profundus. At the proximal interphalangeal joint, the same 20 Newton load produces a 1.1 Newton meter torque load. The 80 newtons in the profundus tension produces only 0.6 Newton meters at the proximal interphalangeal joint. In order for the profundus to flex the proximal IP joint, the distal joint would have to be fully flexed first. This problem is resolved by adding a second tendon at the proximal interphalangeal joint. This tendon is the flexor digitorum sublimis. The sublimis can produce the extra 0.5 Newton meters with just under 67 newtons tension. At the MP joint, we run into the same problem. The load torque is 20 newtons times 0.105 meters, or 2.1 Newton meters. The profundus gives us 0.8 Newton meters torque at the metacarpal phalangeal joint, and the sublimis gives us another 0.67 Newton meters. This time we are approximately 0.6 Newton meters short. We need another 60 newtons of tension force. We get this from the interosseous muscles. These muscles are closer to the center of rotation than the flexor tendons and can accomplish the task with less excursion but greater tension force. Without the added forces distributed at the more proximal joints, a coordinated grip and individual joint control would be impossible. The only grip would be an intrinsic minus type grip. The amount of tendon excursion necessary for a given amount of joint rotation can be calculated from the numbers we have at hand. 90 degrees rotation requires approximately 1.5 times the joint moment arm in excursion. 90 degrees at the distal interphalangeal joint requires 0.75 centimeters excursion. 90 degrees at the proximal interphalangeal joint requires 1.13 centimeters excursion. 90 degrees at the metacarpal phalangeal joint requires 1.5 centimeters excursion. Full flexion requires approximately 3.5 to 4 centimeters of profundus excursion. The profundus has about 6 centimeters of excursion. The other 2 to 2.5 centimeters is used with wrist flexion and extension. If the flexor tendons are not held close to the joints with flexion, the required excursion will increase. 6.5 millimeters of bowstring at the proximal interphalangeal joint will increase the excursion requirements for a fist by another centimeter. Add 3 millimeters of bowstring each at the distal interphalangeal joint and metacarpal phalangeal joints, and a full fist without wrist extension is no longer possible. Bowstringing of the flexor tendons is prevented by the flexor sheath that is reinforced with annular and cruciate ligaments. The odd annular ligaments, A1, A3, and A5, are located over joints and supported by the accessory collateral ligaments. A2 and A4 lay over the proximal and middle phalanges, respectively. The C0, C1, C2, and C3 cruciate ligaments lie between the annular ligaments. Classically, the thumb is described as having an A1 pulley at the MP joint, an oblique pulley over the proximal phalanx, and a distal A2 pulley. There is also an AV pulley between the A1 and oblique pulleys. The V stands for variable, referring to the pulley morphology. There is a chasm in the sublimis tendon over the proximal phalanx and proximal interphalangeal joint through which the profundus tendon passes. This serves several functions, including supporting the profundus tendon against bowstringing and keeping the sublimis tension moment close to the proximal interphalangeal joint. It also allows circulation from the proximal interphalangeal volar plate via the vincula longus to the profundus tendon. This course prevents compression of the vessels by either tendon. If you have made it to this point, congratulations are in order. I sincerely hope you have found something of use in this presentation. Thank you for your attention and thank you for your time.